Dear colleague, dear friends, I would like to thank you for coming tonight to us to have this very important meeting. I would like to thank initially V4 Pharma and the Cardio Clinical Pharmacology Group from Saudi Heart for this meeting. It's really very important meeting for us because we would like always to optimize our medical therapy for our patient. Tonight we have very special speakers. We have Professor Patrick Rosengrold from France, Dr. Abir Bakhsh from Riyadh Business Cardiac Consultant Center. She's consultant heart failure specialist and transplant. And we have Dr. Fakhra Ayubi. She's the president of the Cardio Clinical Pharmacy Group. And they will address very important talk for us really. We'll talk together about RAS inhibition optimization and long-term management of hyperkalemia. As you know, hyperkalemia is really a silent killer. We see it a lot in our patient, and at times we could not do anything about it because we want to optimize their medication, but we cannot. So tonight we will start with Dr. Abir, and she will address for us what's the prognostic implication of hyperkalemia, and then we will be followed by some follow-up questions, and then we have Professor Patrick will talk about RAS optimization and long-term management of hyperkalemia, and then we'll finalize our talk by our really speakers and the president of the group talking about adherence and patient counseling with regarding to hyperkalemia and their medication. So we start now with Dr. Abir. She will address the important topic about the prognostic implication of hyperkalemia. Dr. Abir, please.
Okay, assalamu alaikum and good evening, everyone. And I would like to thank the chairman for the introduction and the scientific committee for inviting me. So I'm going to go over physiology of potassium metabolism, pathogenesis of hyperkalemia and heart failure, and cardiovascular mortality related to hyperkalemia. So as we all know, the normal target for potassium levels is between 3.5 to 4.5 millimoles. And the dietary intake of potassium is per day, it's around 60 to 100 millimoles per day for an average person. And 85% of this intake is excreted in urine, and the rest goes through the GI system. Majority of potassium is taken up after absorption from the GI system to the intracellular space. Only 2% of this is left in the extracellular space in the serum freely. And the sodium-potassium pump and the cellular membrane are the ones responsible for the potassium absorption into the cells. So potassium has a very important role in maintaining a cellular hemostasis in multi-system effect on heart function and nerve impulse transmission, skeletal muscle contraction and smooth muscle contraction, and enzymatic function and DNA synthesis and protein synthesis. There are multiple pathways for potassium absorption and excretion. As we know, that majority of the potassium is excreted by the kidney, 90 to 95%, and 5 to 10% is only excreted by stool. In patients who have chronic CKD, some of the potassium excretion is impaired, and the colon takes on the majority of the responsibility of eliminating the potassium from the system. Once we take potassium, as we said, it's at an average, we're taking 80 to 100 milliequivalent per day, and majority of it remains in the initially it goes to the extracellular space, around 70 milliequivalent. It's up, around 80 to 90% of it's absorbed. It goes to the extracellular space, then it's absorbed within the cells. The muscle takes about majority of that potassium from the extracellular space, including cardiac muscles. Smaller portions will go into the liver, bone, and RBCs as well. And the kidneys is responsible for excreting 90 milliequivalent per day. So what we consume and what we keep inside is a lot less than what we actually had taken in, and majority is excreted. So let's go into hyperkalemia because that's the interest of our talk. So the hyperkalemia is typically defined by potassium levels going more than 5 milliequivalent. And that is in the normal person. A hyperkalemia may be further classified to mild, moderate, and severe, as we see down below. Hyperkalemia can occur rapidly and unexpectedly, and can reoccur frequently in high-risk patients like the patients who have CKD, heart failure, and diabetes. And hyperkalemia is not an acute event that resolves. It's actually a chronic and intermittent and frequently occurring event. Mild hyperkalemia is defined as 5 to 5.5. Hyperkalemia is 5.5, moderate is 5.5 to 6, and above 6 is considered severe hyperkalemia that is associated with high adverse event. And hypokalemia is when the levels are less than 3.5. So in heart failure, why do we see hyperkalemia? So in congestive heart failure, there are multiple mechanisms leading to hyperkalemia. There is congestive heart failure where you have reduced renal perfusion, reduced sodium absorption. Majority of the sodium reabsorption actually occurs in the proximal tubules. So there's not much sodium left in the distal tubules. And because as we have seen, the potassium excretion or exchange is dependent on the level of sodium or sodium dependent cotransport. So there's not a lot of sodium left in the distal tubular system in heart failure patients, so there's less potassium excretion in the distal tubules. Heart failure patients also have the triad of renal impairment, either from cardiorenal syndrome, diuretic use, and the use of RAAS inhibition. This all combined together can lead to hyperkalemia. Also, the sympathetic nervous system blockers, which are beta blockers, they also have a role in increasing the levels of potassium, not only RAAS inhibitors, because the beta blockers or the sympathetic nervous system is responsible for regulating renin release as well. So beta blockers or sympathetic nervous system blockers will also reduce the potassium shift into the cells. Diabetes, majority of our population, heart failure population, they have diabetes around 40% or even more. And these patients also have reduced potassium shift into the cells due to the unavailability of the insulin. So when does hyperkalemia occur? When the balance between potassium intake and removal is disturbed. So ideally, we should have, if you have reduced renal filtration and excretion, you'll have more hyperkalemia. If you have less colonic excretion or reduced cellular uptake, as we have mentioned. Other things would be increasing dietary intake, medications that would increase hyperkalemia, and factors that cause increase in cellular release of the potassium. And we said that, as we showed earlier, in heart failure, there are multiple mechanisms are working together. You have reduced excretion, reduced cellular uptake, and as well as increased level of potassium due to medication. In the hyperkalemia is difficult to diagnose because usually it's asymptomatic. And the first presentation may usually be a arrhythmia or sudden cardiac death. Symptoms are not specific, and patients sometimes present with fatigue, weakness, palpitation. As we said, may have some neurological symptoms like paresthesia. They may have cardiac abnormalities, which are arrhythmias and sudden death. But unfortunately, it's not something that you can pick up early. These symptoms occur when the potassium is already severely elevated. And they're variable from patient to patient. So patients who have baseline higher levels of potassium may not exhibit the same symptoms as someone who had acutely developed hyperkalemia. So why are we concerned about hyperkalemia in the heart failure population? So several studies that actually looked at rate of hospital admission and mortality in patients who have hyperkalemia. So patients who have cardiovascular disease, and this is a cohort, a retrospective cohort who looked at more than 50,000 patients with cardiovascular disease and who were taking antihypertensive medication. And these patients had developed, around 25% of this cohort had developed severe hyperkalemia in this retrospective analysis. 6.25% of these patients had died, and compared to patients to only 2.9% of patients who had normal kalemia. So there is a significant association mortality with patients who have hyperkalemia and compared to normal kalemia. And these are cardiovascular disease in general, patients who had cardiovascular disease, not heart failure specific. And hospitalization occurred also at a significant percentage, 7.8% of these patients with hyperkalemia compared to only 5% of patients who had normal kalemia. So if you're looking at a cohort of cardiac patients, you have increased risk of hospitalization and mortality if they have hyperkalemia, and you can pick that up in your follow-ups. A lot of these patients have comorbidities, as we know. They have CKD, diabetes, coronary artery disease, peripheral vascular disease. These are all independent risk factors of hyperkalemia. So if you have combined comorbidities, then the risk of developing hyperkalemia and further adverse events are higher. And when looking at a heart failure population, and this is a study from the UK, they had looked at around 20,000 patients. And as you see down below, hyperkalemia has significantly was associated with in-hospital mortality. In addition to other risk factors as age, more than 75, ischemic etiologies, also having comorbidities such as renal impairment and COPD. So certain parameters have a higher mortality, in-hospital mortality for heart failure, and hyperkalemia is one of these mortalities. So one of the interesting things is that potassium monitoring is necessary not just when patients are hospitalized, but also after discharge. And patients who have persistently elevated hyperkalemia, they may actually have persistently elevated risk of mortality. And this is a U-shaped curve, as you can see. So in this population, they actually had a mean of potassium for the heart failure patient was 4.5. But if you look at the patients who had hypokalemia less than 3.5, closer to 2.5 chronically, and these patients were followed up post-discharge as well with regular potassium checks. So patients who have hypokalemia and patients who had hyperkalemia both actually had very high risk of mortality. All-cause mortality was, or the survival, this curve showing you the survival. So survival for patients who had severe hyperkalemia more than 5 was the least. So at the end of follow-up, survival was only 70% compared to around closer to 80 for the patients who had normal kalemia. And I think that the difference is more clear in the first year or two, because the long term, as we know, the mortality of 5-year mortality is high in general for heart failure population. But if you look at around 1 to 2 years, the difference is more obvious for patients who had normal kalemia, which is these lighter lines, compared to patients who have had hyperkalemia, and also patients who had hypokalemia had less survival compared to patients with normal kalemia. And similarly, and very interestingly, patients who had hypokalemia and persistent hypokalemia had worse outcome than patients who had hypokalemia and then went to normal kalemia. But patients who had hyperkalemia and persistent hyperkalemia or hyperkalemia then went to normal kalemia in outpatient setting, both actually had very poor prognosis and reduced survival and long-term follow-up. So even hyperkalemia, if you had like episodic and not persistent, it is still associated with significantly reduced survival compared to patients who had normal kalemia or even hyperkalemia and normal kalemia. So when you look at further into the comorbidities associated with heart failure, so you already have heart failure, and we understand that the prognosis with hyperkalemia is poor. And if you add to that chronic kidney disease and diabetes, the prognosis would get furtherly decline. So in this retrospective, again, this was another retrospective study that they looked at a cohort of 50,000 patients with heart failure and comparing to a normal population. Patients who had, again, you have 2 peaks here of mortality in patients who had severe hypokalemia or patients who have severe hyperkalemia. And the peak starts from more than, when you have a potassium level more than 5.5, then you start seeing a peak of mortality. Patients who had very severe, these numbers were actually very small, but the mortality was still high. But I think the focus here at, at any levels of more than 5.5, you have higher risk of mortality from in heart failure population, and as well as the group who have a less than 3.4, 3.5, and around 2.5 levels of potassium. So there is, as we have seen in the previous cohort, this is also have giving you the same information that you have a bimodal kind of or a U-shaped curve for mortality in patients with, if you look at potassium levels. So both hypokalemia and hyperkalemia are associated with higher mortality, both in patients with heart failure and CKD as well. And in diabetes also, you had patients who had higher levels of potassium, they had higher mortality. And the last curve here is combining all comorbidities and levels of potassium. And there's a very significant rise in mortality when you have a combined, if you look at the combined comorbidities, heart failure, diabetes, CKD, and levels of potassium across the spectrum of hypo and hyperkalemia. And again, this is the same re-representation of what we had just mentioned, that compared to the control group, patients with diabetes significantly have higher mortality with levels of potassium. And more than that, if you combine all the comorbidities, you have higher levels of mortality. So these are risk factors that we have to keep in mind when we are following up our patients. And again, if you there's a tenfold increase in death in patients with CKD and presenting with hyperkinemia, and this study was focused on patients with CKD and stage 3 and stage 4, so very advanced renal dysfunction, which sometimes we are encountering in our heart failure population as well. And this adds, unfortunately, increase the multifolds of mortality in our patients. So in conclusion, hyperkalemia is prevalent in the heart failure population, and there are multiple triads and mechanisms that can explain why. Presence of hyperkalemia is associated with increased risk of hospitalization and mortality in the heart failure population. And when you combine comorbidities such as diabetes, CKD, you have further increased risk of hyperkalemia and further increased risk of hospitalization and mortality. Thank you.
Thank you very much, Dr. Abir. I really enjoyed your talk and very fruitful and very informative. Now, I will leave the question to the end. Now we have a poll for the attendee to answer. So if you can put the poll, please, for us. Thank you. So the question here, hyperkalemia is a chronic recurrent condition that increases the risk of mortality in CKD and heart failure. True or false? I want you to answer the question, please. And we'll give you about 1 minute to answer it and submit it. So the answer here, 93 said yes, well done. And regarding a long-term chronic management of hyperkalemia is achieved by oxalate, loop diuretics, seems to be loop diuretics, most of them, and Batimore, and optimizing RAASI. So we will now see how the talk will be about the long-term management of hyperkalemia, and then we will take it from there for another poll after the Professor Patrick talk. Now, we'll move now to Professor Patrick, and I would like really to thank BFARM Pharma for their really inviting Professor Patrick Kroskonol. He's a nephrologist and vascular medicine specialist. He's certified from the European Society of Hypertension as hypertension specialist. I'm very, very pleased to hear him, because we have somebody who's already interested in hypertension and nephrology as well. And he's professor of therapeutic at University of Lorraine. So Professor Patrick, please.
Thank you very much for this very kind introduction. I would like to thank the organizers. I would like to thank the Vifor Pharma company for this very kind invitation. I'm very proud to be here tonight with you. Hopefully next time face to face, but this is a great opportunity for me to present this very appealing data, as you will see. So this talk is entitled, as mentioned by Professor Arafat, RAASI optimization, long-term management. These are my disclosures, and I have to acknowledge that I was privileged to serve as steering committee member of the Amber trial I will present later on. I'm now proud to serve as steering committee member in the Diamond trial, which is ongoing, which I'm going to present later on. So in the first part of my talk, I will try to convince you that we have an issue with hyperkalemia on RAASI, because there is a true dilemma here for the management, for the optimization of our cardiorenal patients. Because on the one hand, we know that renin-angiotensin-aldosterone system inhibitors are proven to preserve kidney function and delay progression to end-stage renal disease in our CKD patients. We all know that they decrease proteinuria, that they decrease blood pressure, they enable a better blood pressure control, so a nephroprotective effect. And in the heart failure setting, they also decrease all-cause mortality. This is a matter of fact. But knowing that RAASI are being widely used, but we know that they may cause or worsen hyperkalemia. So I will try to convince you. First of all, RAASI are demonstrated cardio-renal protective drugs in the cardiorenal continuum. First of all, the example of diabetic nephropathy. This is the most widespread used nephrology model to run clinical trials. And for instance, back to the renal data, it was shown that a reduction in albuminuria was also associated with a reduction in the cardiovascular risk. And this slide presents us that the greater the extent of proteinuria, microalbuminuria reduction, the better cardiovascular prognosis. Furthermore, if we consider a meta-regression of the trials implemented within the framework of diabetic nephropathy, you see here that the higher the doses of S inhibitors, ARBs, the higher the reduction in albuminuria. Therefore, it is of paramount importance to maintain RAASI to achieve a better kidney prognosis. So cardiovascular prognosis and renal prognosis. What about heart failure drug treatment? I was privileged to author this review published in The Lancet last year with my co-authors on one very key feature is that there are few areas in medicine comparable to heart failure with reduced ejection fraction, because so much improvement was triggered by clinical trials on which repeatedly, convincingly demonstrated that ACE inhibitors, beta blockers, MRAs are truly the cornerstones of therapeutics. And the use of these drugs was actually associated with a major improvement of outcomes in heart failure on reduced ejection fraction patients. And by the way, 2 out of 3 of these drugs are RAASI, ACE inhibitors, MRAs. And the latest guidelines also introduced ARNI, another RAASI, within this armamentarium. So there is a tremendous evidence, this is a 1A recommendation, that we must use this drug to improve our patients' outcomes should they present with heart failure and reduced ejection fraction. The point is that all these RAASI may induce hyperkalemia. And actually, hyperkalemia is an inherent risk of is associated with an inherent risk of inducing hyperkalemia. This is true for S inhibitors, ARB, ARNIs, and mineralocorticoid receptor antagonists. So they do decrease sodium retention. They have a number of effects, but they may induce hyperkalemia. And as nicely showed my previous colleague, hyperkalemia is often diagnosed in renal patients. This is again the VA cohort of more than 200,000 participants, showing that the lower eGFR, the higher the probability of experiencing hyperkalemia, which along with RAASI intake was associated with the risk of presenting hyperkalemia. And another interesting cohort is that implemented in Sweden, just to figure out how to predict the risk of experiencing hyperkalemia with initiating a RAASI. So this data stem from the Swedish SCREAM project. Almost 70,000 new users of S or ARBs. And a risk score was established, which encompassed gender, potassium levels, eGFR, diabetes mellitus, yes, no, heart failure, yes, no, the use of potassium-sparing diuretic, yes, no, and several scenarios are proposed. For instance, scenario number 1, a woman with a potassium of 4 millimole per liter, a mildly impaired GFR, 55 milliliters per minute, with diabetes, without heart failure, without a K-sparing diuretic. And you see here the risk of experiencing hyperkalemia above 5.5 over a year is 2.1%. But now, should we consider a woman slightly elevated potassium, 4.5, but a severe eGFR impairment, 20 milliliters per minute, diabetes, still no heart failure, no K-sparing diuretic. And now, what about the 1-year risk of experiencing hyperkalemia? It does rise to 26%. So it's easy to figure out that our kidney patients, our diabetic patients, our heart failure patients, the older they are, the higher the probability to ultimately experience hyperkalemia should they be treated with RAASI in order to improve their cardiovascular and renal outcomes. The point is that hyperkalemia is associated with poor clinical outcomes. On this slide, my colleague nicely explained to us that there is actually a U-shaped relationship between serum potassium and outcomes. Therefore, we must pay attention to hypokalemia and hyperkalemia. And in the left-hand side picture, these are data from a large electronic health record data set showing that whatever whichever could be the comorbidities, there is a U-shaped relationship on concerning hyperkalemia. It is associated with an increased risk of mortality. And as you see here in the left-hand side panel, the burden of comorbidities adds to the burden of hyperkalemia by itself. In other words, should you be diabetic plus CKD plus heart failure patients, the strength of the relationship between hyperkalemia and outcomes is even stronger. On the right-hand side panel, again, the U-shaped relationship in chronic heart failure patients. These are Spanish data. And I wish I may emphasize again, because this is a very interesting study, because for the first time, it was shown that those patients who were normalized after experiencing either hypokalemia or hyperkalemia ultimately experience better outcomes. So this means that the proper monitoring followed by normalization of potassium, of course it is an observational study, is or might be associated with better outcomes. Back to cohorts, CKD cohorts primarily, but also general populations. You see here that again, there is a U-shaped relationship between serum potassium on all-cause mortality, cardiovascular mortality, end-stage renal disease. And I wish I may insist on the top right-hand side panel on all-cause mortality across the eGFR strata, because some of us may hypothesize that our patients could be somehow protected from the risk associated with hyperkalemia because they are CKD patients. Actually, this is not true at all, because as you see here, the risk associated with hyperkalemia is similar in patients with an eGFR above 60, between 30 to 60, and below 30. So all our CKD patients are exposed to unfortunate outcomes associated with dyskalemia. So what about the risk associated with hyperkalemia in patients treated with RAASI? This is what I refer to actually, because back to the heart failure and reduced ejection fraction trials, the RAASI trial, which did compare spironolactone with placebo, a major improvement of outcomes. As you see here, there is still a U-shaped relationship between serum potassium and outcomes. In other words, hyperkalemia was associated with higher incidence of mortality. But interestingly, whichever could be the serum potassium levels, outcomes are better under SPIO compared to placebo, which means that should you experience hyperkalemia, it would be better for you to be on SPIO compared to be on placebo, because the benefit of SPIO relative to placebo was maintained. So we need to deal with the risk associated with hyperkalemia and do our best to maintain RAASI. Unfortunately, hyperkalemia is a trigger to RAASI discontinuation. And again, this is electronic health record data here from the US. And as you see here in the left-hand side panel, RAASI therapeutic was stopped or reduced even in patients with mild hyperkalemia between 5.1 to 5.4 millimole per liter, 38%. On the right-hand side panel, patients with serum potassium above 5.5, almost half of the patients got either down titrated or discontinued RAASI in the setting of hyperkalemia. So hyperkalemia is one of the major triggers of reducing or discontinuing RAASI. Back to Europe, Swedish registry data where predictors of hyperkalemia were studied in new users of mineralocorticoid receptor antagonists. And it was shown that after hyperkalemia, almost half of the patients got discontinued, 10% reduced the prescribed dose. And unfortunately, when MRA was discontinued, most patients, 76%, were not reintroduced to therapeutics during the subsequent year. So it's a double penalty actually, because patients who experience hyperkalemia are exposed to a higher risk of death, and they are exposed to a risk of discontinuing RAASI. And we dig further onto this within the framework of the ESC heart failure registry, chronic heart failure patients, almost more than 9,000 patients. I led this analysis we published a couple of months ago. And as you see here in this first graph, presenting the multivariable analysis for clinical predictors of low dosage of mineralocorticoid receptor antagonists at baseline, as you see here, the higher the serum potassium, and this was true both for mild hyperkalemia and for moderate hyperkalemia, the higher the serum potassium, the higher the probability to get low doses of MRAs. What about the probability of experiencing treatment discontinuation over a period of time of 1 year, treatment discontinuation of MRA? As you see here, patients with hyperkalemia above 5.5 got almost 2 times increased rate of MRA discontinuation over 1 year. Finally, what about the relationship between serum potassium and outcome in this population? Again, the same kind of fusion relationship between serum potassium and all-cause death, the top panel, CV death on the bottom panel. And we performed a multivariable analysis to determine which were the baseline factors associated with all-cause death in multivariable analysis, considering subsequent RAASI discontinuation during this 1 year follow-up. And yes, as you see here, considering RAASI discontinuation, S inhibitors discontinuation, IRB discontinuation, MRA discontinuation were found associated with poorer outcomes, 13 times higher rate of all-cause death, 6 times higher, 10-fold higher. So very high level of a very high probability of experiencing death. And in this setting, baseline serum potassium was no longer associated with outcomes. And subsequently, we performed what we called multivariable mediation analysis for SES, ARB, MRA discontinuation. And actually, hyperkalemia above 5.5 was found associated with mortality and cardiovascular mortality by mediating discontinuation of S inhibitors, IRB, not statistically significant, on MRA. So this is again a double penalty because hyperkalemia triggers RAASI discontinuation, which in turn triggers poor outcomes. On how to visualize this, we published a couple of months ago this cardiovascular risk score calculator, which you may find easily first in this European Journal of Heart Failure paper. On this calculator is available online freely. Just to give you an example, this is a 60-year-old man, a history of heart failure. Is treated with an MRA, BMI of 26, systolic blood pressure 124, heart rate 72, NIA class 2, anemia, yes, potassium, EGFR 46, and potassium 5.7. If you just fill in this formula, you get the information that the risk associated, the CV death rate is moderately elevated, which means that the 6-month survival probability is 92%. Now, so with MRA ongoing, but potassium of 5.7. But now, should you consider the discontinuation of MRA? Discontinuation of MRA under the same all other features, BMI, systolic blood pressure, potassium 5.7, EGFR 46. Now the CV death rate increases up to with a lower 6-month survival probability. This is now a highly elevated CV death rate of the survival decreasing to 87% at 6 months. So if we discontinue RAASI in this hyperkalemic setting, the probability of dying increases. But now, if we maintain RAASI and we normalize potassium, and we will see in the second part of my talk how we may proceed to do that. So potassium is now 4.5, and as you see here, the CV death rate is much lower. The 6-month survival probability is now 96%. So maintaining MRA on normalizing potassium was found associated with better outcome. This data stems from the Ephesus database, the MRA, the famous MRA trial, and from the Emphasis HF database, the other trial, which led to the 1A indication along with the RAAS trial. So, but as nicely showed my colleague, it is of paramount importance to properly monitor potassium, because if you don't monitor properly potassium, you just cannot detect potassium abnormalities. And in the real life setting, it was unfortunately repeatedly shown on the top panel, these are US data, that downstream the initiation of MRA, a proper monitoring of potassium is unfortunately poorly implemented. You see here that less than 30% of the patients got monitored with potassium within 3 months. And things are not better in Europe because less than a quarter of heart failure patients initiated an MRA received guideline recommended potassium monitoring. So it should be at this stage mentioned that in order to achieve a precision medicine, bioprofiling, and to retrieve the best benefits of life-saving drugs, we need to properly monitor EGFR and potassium as we propose with Fayez Zanad in a circulation white paper. And actually, this is exactly what is recommended by all guidelines. Just an example here, the ESC guidelines, which recommend to use a proper monitoring to adapt the doses of RAASI, proper monitoring of potassium and creatinine. So there is, as a conclusion for this first part, there is undoubtedly an unmet need because the increased use of ACE, ARB, or MRAs has unfortunately resulted in an increased awareness of the risk of serious worsening of renal function or hyperkalemia. On this fear inducing worsening of renal function or hyperkalemia has unfortunately limited the initiation or increase in dose of those life-saving drugs in patients with heart failure and CKD. Therefore, there is a clinical need for chronic hyperkalemia treatments that are effective, safe, and well tolerated to enable use and optimization of RAASI therapeutics. And so far, what are the current treatment options for chronic hyperkalemia? Unfortunately, they display significant limitations. I will try to list these current treatment options. We may consider a dietary potassium restriction, but actually this may not be sustainable on the long run because many cardiorenal patients already have other restricted diets. And furthermore, potassium is a common ingredient in healthy food, the DASH diet, and preventing patients from eating healthy diet may not be a wise solution, actually not sustainable on the long run. Well, what about RAASI reduction? I hope I have convinced you. I think we are all convinced that RAASI reduction is not the good solution because limiting the dose or discontinuing treatment of drugs known to be effective in these populations may expose them to poor outcomes. What about the potential use of non-potassium sparing diuretics? Actually, this is something interesting to consider, but I don't think it is a good option because of the side effects. The increased risk for gout, diabetes, volume contraction, worsening renal function. And by the way, we all know that increasing the doses of fluid diuretics or thiazide diuretics will further overstimulate the renin-angiotensin-aldosterone system, which is exactly what we don't want. So using non-potassium sparing diuretics to decrease potassium is not a good solution in my opinion. What about sodium bicarbonate? This is usually reserved to patients with severe acidosis. They may require multiple pills, medication adjustments, and it is also difficult to give salt to our patient with CKD without exacerbating volume status or blood pressure. Finally, what about the old generation potassium binders, that is CPS or SPS? They are unfortunately limited safety and efficacy data. We all know that they are not well tolerated and that their use can be associated with potentially life-threatening side effects, including intestinal necrosis. And there were some safety warnings released from the FDA toward SPS. There is also a risk of hypokalemia, and this treatment should be discontinued as soon as serum potassium falls below 5 mmol per liter. With regard to SPS, there are special precautions related to sodium because SPS exchanges potassium versus sodium, and this may trigger fluid overload, which may happen to be harmful in our CKD and our heart failure patient. Furthermore, as I mentioned earlier on, SPS use was found associated with a higher risk of severe and minor GI adverse events with a special warning released by the FDA. Fortunately, there are new kids on the block, new potassium binders, Potassium, but also ZS, and potentially a new era for the treatment of hyperkalemia because these two potassium binders are widely approved. Just to give you an example, Potassium was approved by the FDA 5 years ago, 3 years ago by the EMA. Sodium zirconium cyclosilicate was approved by the EMA and FDA 2 years ago. So there are now some expert opinions which recommended new these new potassium binders as potential solution for the treatment of heart failure patients on RAASI treatments. So initially, 2016, it was stated that these drugs were not, they were under consideration for regulatory approval. Also, Potassium was already approved. 2018 ESC expert consensus document recommends maximizing RAASI dosing whenever possible in most patients with cardiovascular disease on chronic or recurring hyperkalemia. And importantly, in 2019, an HFA expert consensus document stated that in selected patients, Potassium on ZS9 may enable use of MRAs on other RAASI in more patients at higher doses. But it is not known whether this will improve patient outcomes. I will come to that later on. What about ZS? Actually, to be crystal clear, here there are limited data concerning ZS, and actually I'm not aware of any data showing that ZS may enable RAASI, and this is most likely the reason why the ZS provider decided to set up a dedicated trial, the prioritized HF trial, to determine whether this compound may help optimizing RAASI inhibition with reducing potassium. But the trial was terminated prematurely, stopped earlier on this year during the COVID-19 pandemic. So I have no idea whether this may lead to conclusive results or not. As a contrast, there are lots of data concerning Potassium on RAASI enablement. This is what I'm going to show you during the second part of my talk. What about Potassium? This is, first of all, a sodium-free polymer. It is a new generation sodium-free polymer which exchanges potassium versus calcium. So this polymer displays the high potassium binding capacities. It is non-absorbed. It is administered once a day with a starting dose of 8.4 grams, which may be increased or decreased by 8.4 grams as necessary to reach the desired target range, up to a maximum dose of 25.2 grams daily. There was a comprehensive portfolio of research and development trials. For the sake of time, I cannot go through all these trials, but I will rather insist on several of them, which in my opinion, provide compelling data on the RAASI enablement feature achieved by Potassium. So the Amethyst diabetic nephropathy study, this was a phase 2 trial where diabetes type 2 patient with KD hypertension under stable RAASI doses for more than 4 weeks on microalbuminuria or a serum potassium above 5 on below 6. In other words, these were CKD patients, heart failure patient in a third, hypertensive patient, diabetic patient on RAASI in all cases. And they were treated with several doses of Potassium with the randomization to the different doses as a function of the severity of the hyperkalemia, either mild hyperkalemia or hyperkalemia. And what is interesting in this trial, this is a long-standing period of observation, a year. And as you see here, whichever could be the strata of potassium, there was a normalization of serum potassium early on, after 3 and then 3 days on 7 days, which got maintained over the course of the study 1 year. And this is of paramount importance. The compliance to the study drug was just outstanding. 86 to 95% across those groups on strata tolerated this drug. And you see that the patients really need this drug, because once the drug is discontinued, there is a rise in serum potassium again, because there are still patients treated with RAASI. Interestingly, in these patients treated with RAASI and maintained under RAASI with Potassium, with potassium being normalized, there is a significant blood pressure reduction. Also, of course, we cannot conclude that it is due to Potassium, but this is no doubt beneficial in this patient, but it is open label. This is data from systolic blood pressure. These are data from diastolic blood pressure. On another trial, the pivotal trial, phase 2 trial, included CKD 3-4 patients with hyperkalemia between 5.1 to 6.5 millimoles per liter using RAASI again. Baseline comorbidities, CKD 100%, heart failure 42%, diabetes almost 60%, hypertension 97%, all of them treated with RAASI. In the part A of the trial, patients were all treated with Potassium with different doses as a function of the severity of hyperkalemia. In other words, for mild hyperkalemia between 5.1 to 5.5, Potassium 4.2 BID, starting dose, moderate to severe, 8.4 BID, starting dose, for baseline serum potassium 5.5 to 6.5. And for this part A, the primary endpoint was mean change in serum potassium from baseline to week 4. Secondary endpoint, the proportion of normal kalemic patients at week 4. And then, interestingly, for those patients with initially moderate to severe hyperkalemia who got normalized under Potassium and still on RAASI, there was a randomization to Potassium or placebo on again 8 weeks of follow-ups with a primary endpoint, which was treatment group differences in median changes in serum potassium from start of part B to part B at week 4, after our first visit where serum potassium was between 3.8 to 5.5. I will go briefly through the results. As you see here for the part E, where all patients were treated with Potassium with different doses as a function of the severity of hyperkalemia. On the left-hand side panel, you see the kinetics of serum potassium with a decrease already after 3 days, then 1 week maintained throughout the 4 weeks. And as a consequence, you see here the primary efficacy endpoint, which was achieved here with all subjects a -1 millimole per liter, a p-value of 0.001, so highly significant result toward the reduction of baseline elevated serum potassium. And in parallel to that, interestingly, you see here that during this first part of the study, there was an interesting decrease in serum aldosterone, which was, by the way, expected because we do decrease serum potassium, but also a decrease in systolic blood pressure, diastolic blood pressure, and of urinary albumin excretion. This is no doubt interesting. During the second part, as I mentioned, those patients treated with Potassium and under RAASI who got normalized were assigned after randomization to either Potassium continued or placebo. And as you see here, these are the main results. So back to the first A decrease in serum potassium. And if we switch patients to placebo, there is a rise in serum potassium, while patients maintain on Potassium maintains the normalization. So these are data for potassium, but in parallel, you see here striking results concerning serum aldosterone, because there was a decrease during the first phase, as I mentioned earlier on, which was maintained in patients continued Potassium, while those patients switched to placebo displayed a rise in serum aldosterone. What about the adverse events? The percent of serious adverse events was very modest. Only very few patients displayed a serious adverse event. On the randomized withdrawal phase, none of the patients treated with Potassium displayed serious adverse events. The most common adverse event being mild GI effect constipation, which, by the way, as we knew from other trials, mostly resumed even if Potassium was continued. And interestingly, during the initial treatment phase and throughout the follow-up period, the incidence of hypokalemia was 3%, therefore very uncommon, which is of paramount importance because we must avoid hypokalemia, and this is the case with Potassium. And again, serum potassium, I already showed you that there is a rise on aldosterone if you switch patients to placebo. But what about blood pressure? Again, a decrease in blood pressure in patients assigned patiomer compared to those assigned placebo. This was systolic blood pressure, a similar kinetics for diastolic blood pressure. And if we now consider RAASI on the left-hand side panel, you see that the proportion of patients with dose reduction or discontinuation of RAASI due to hyperkalemia at the end of week 8 was largely decreased in those patients assigned patiomer compared to placebo. Because as you see here, dose reduction in RAASI happened in 66% patients of the patients treated with placebo, compared to only 6% of patients treated with patiomer. On what about discontinuation of RAASI because of hyperkalemia, 56% of patients treated with placebo compared to 6% of the patients treated with patiomer. On what about the proportion of patients of RAASI? On RAASI at the end of week 8, 94% of the patients on patiomer compared to 44% of patients treated with placebo. Therefore, this is an exploratory analysis here, but in my view, already very interesting data. Another trial, a different one, a phase 2 trial, further substantiate the RAASI enablement achieved with patiomer. In this trial, patients with heart failure with an indication to receive Spiro with CKD or documented hyperkalemia that led to discontinuation of RAASI of beta blocker within 6 months. These were, in other words, CKD patients, all of half of the population, heart failure patients, 100%, diabetes type 2, a third, treated with RAASI in almost all the cases. They were assigned to patiomer or placebo on top of Spiro, 25 milligrams a day, which might be subsequently up-titrated to 50 milligrams a day. And as you see here, in those patients treated with patiomer, there was a maintenance of a normal serum potassium. And interestingly, if we consider the occurrence of hyperkalemia on the proportion of patients on 50 milligrams a day of Spiro, you see here that 25% of the patients treated with placebo experienced hyperkalemia compared to 7% of the patients treated with patiomer. And what about the rate of tolerating 50 milligrams a day of Spiro? It was increased in those patients treated with patiomer versus placebo. Another trial where at that time, the primary endpoint was RAASI maintenance. We selected a CKD population with resistant hypertension. This is the aim of the AMBER trial, because you know that based on the Pathway 2 trial, it is now, at least from the ESC guidelines, recommended to use Spiro in those patients with resistant hypertension, as long as their eGFR is above 45 and their serum potassium is below 4.5. But what to deal with other patients with lower eGFR? We considered these patients for the AMBER trial. So resistant hypertension, all with RAASI, normal serum potassium, 4.3 to 5.1 as a maximum. And we randomized them after a run-in phase to either Spiro plus patiomer or Spiro plus placebo. The primary endpoint being the RAASI enablement effect, that is the difference between treatment groups in the proportion of patients remaining on Spiro at week 12. The secondary endpoint being the difference in AOBP at week 12. The primary endpoint are presented here. Patients who remained on Spiro at week 12, 86% on patiomer compared to 66% on placebo, a compelling results with a p-value of 0.0001. On the right-hand side panel, the Kaplan-Meier curves of time to discontinuation of Spiro, as you see here, again, 0.0001. That is, patients remain more frequently on Spiro when treated with patiomer. And what about time to discontinuation? What about time to hyperkalemia above 5.5? Among patients treated with placebo, 2 out of 3 developed hyperkalemia above 5.5, while patiomer reduced the risk of hyperkalemia by half. Very compelling results again. What about blood pressure? Considering here that blood pressure was actually decreased in both groups, on Spiro plus placebo, on Spiro plus Patiomer, a very significant decrease of -10 to -11 mercury millimeter, but no statistical difference between group difference comparing Patiomer or placebo. But this was a short-term trial, and we learned from Spiro metabolite on Spiro dosages that was a true remnant effect. Most of patients were discontinued Patiomer, were discontinued Spiro after 8 weeks. And after week 12, many patients, at least a third of them, displayed detectable Spiro levels, which may have contributed to the absence of difference between both groups in terms of blood pressure. And there was an interesting pre-specified analysis in heart failure subgroup as defined by the investigators. These are the baseline features. This was an interesting subgroup because almost half of the patients enrolled in AMBER were heart failure patients. Compared to the patients without heart failure, those patients with heart failure were more frequently presenting atrial fibrillation. They were more frequently treated with beta blocker. What about the type of heart failure? These were mostly patients with a preserved ejection fraction, what I would say, with an average ejection fraction of 50% on average. But reduced ejection fraction was well represented, 41%, 43%. And again, percent of patients who remained on Spiro, you see here 84% of patients treated with Patiomer compared to 68%. And the p-value for interaction between subgroup without heart failure with heart failure was not significant. On time to discontinuation of Spiro in the heart failure subgroup was statistically significant. The mean difference in cumulative Spiro dose between the two groups was 387 milligrams over these 12 weeks. And we concluded from this analysis that the results were consistent with those in the ITT population, being non-significant for interaction between heart failure and no heart failure. And again, the blood pressure pattern, a statistical difference in blood pressure, both in patients with heart failure and patients without heart failure, but a non-statistical significance for interaction between subgroups. And again, the results were consistent in the ITT population, being non-significant for interaction between heart failure and no heart failure. I should mention that the primary results of the trial were published in the Lancet, while the secondary results were published recently in the European Journal of Heart Failure. What about the adverse events in the overall population on the patient population with heart failure? As you see here, serious adverse events were really uncommon, even in the overall population, and were, if any, more common in the placebo group, 3% plus Spiro, compared to the Spiro plus Patiomer group, 1%. And none of them was attributed to the study drug in the opinion of the investigator. And if we consider patients with heart failure, 3 patients under Spiro plus placebo versus 0 under Spiro plus Patiomer. And what about adverse events leading to study treatment discontinuation? Hyperkalemia, 7% under Spiro plus placebo versus 1% under Spiro plus Patiomer in the overall population, 1 versus 0 in the heart failure population. And we concluded that from this trial, again published in the Lancet for the primary results, that in advanced CKD with resistant hypertension, Patiomer enables more persistent use of Spiro. Among patients treated with placebo, 2 out of 3 developed hyperkalemia. Patiomer reduces this by half. Results in patients with heart failure were found to be consistent with the overall results, the p-value being non-significant for interaction between subgroups with and without heart failure. And Patiomer use in heart failure patients allowed more spironolactone use, 388 milligrams more over 12 weeks. On Patiomer safety profile in patients with heart failure was found to be consistent with previous reports, and therefore AMBER added placebo-controlled data to the safety database. Before I conclude, I will show you an interesting study, because you may ask me whether Patiomer should be used with or without food, because there must be a 3-hour separation between other drugs intake and Patiomer use. And actually this trial was specifically, the Tourmaline trial was specifically designed to address this question. all patients were treated with Potassium, but were either treated with food or without food. On Potassium was administered 8.4 grams QD with titration if needed. And as you see here, the kinetics are similar. Therefore, Potassium may be used with or without food. And as a conclusion, what data do we have for Potassium enabling effects towards RAASI enablement? So I presented you the OPAL trial data, 94 versus 44%. These are placebo-controlled data. This stem from a trial where patients initially hyperkalemic were randomized to placebo or Potassium after initial normalization under Potassium. In heart failure patients, the PERLA-CHEF trial, again, a RAASI enablement effect, placebo-controlled data. On the dedicatively designed trial, the AMBER trial results, where for the first time, the primary endpoint was the RAASI enablement on compelling data. Therefore, I may conclude that Potassium, of course, is a proof for the treatment of hyperkalemia, but there are compelling data already demonstrating that this drug enables substantially more patients to remain on their RAASI medication at the end of study compared to those given placebo. And one may wonder whether this may ultimately translate to better cardiovascular outcomes. We don't know. There are tips, there are clues that this may be the case. But this is exactly the aim of the DIAMOND trial, which is ongoing, to determine if Potassium treatment of subjects who developed hyperkalemia while receiving RAASI medications will result in continued use of RAASI medications in accordance with heart failure treatment guidelines, and thereby decrease the occurrence of combined endpoint of cardiovascular deaths and cardiovascular hospitalization events compared with placebo treatment. The DIAMOND trial is ongoing. Last, a short case report to demonstrate in the real-life setting the RAASI enablement. This is an interesting case report published by Spanish colleagues. I will be brief in that. A 70-year-old Caucasian male with a history of diabetes type 2, hypertension, hypercholesterolemia, CKD stage 3, a history of atrial fibrillation, ischemic heart disease with acute myocardial infarction in 2009, with the corresponding coronary angiogram. And after the MI, the patient developed heart failure with reduced ejection fraction. He presented several acute decompensations requiring hospital admissions. And in the latter admission, he displayed an ejection fraction of 34%. The patient was discharged NIA class 2B with suboptimal medical therapeutics. And then he was included in a multidisciplinary chronic heart failure management program, which aimed at intensive health education and careful pharmacological titration. And during follow-up, low dose of S inhibitors, enalapril, beta blocker, nebivolol, and MRA epinephrine were initiated sequentially as per current clinical guidelines. And this was a success for beta blockers, but the same did not occur for enalapril and epinephrine. Both had to be discontinued 2 weeks after initiating epinephrine due to deterioration of renal function and hyperkalemia, 6.3 millimole per liter, this was asymptomatic. Blood tests showed a recovery of renal function on potassium levels a week after. A few weeks later, in a second attempt to use S inhibitors, low dose of ramipril, 1.25 milligrams a day, were initiated. But despite the very low dose, potassium level raised again up to 6.1 millimole per liter, eGFR unchanged. Ramipril was discontinued. The patient was once again questioned about dietary habits, with no evidence of intake of potassium-rich food, supplement, or other preventable cause of hyperkalemia. And to further facilitate attempts to optimally inhibit RAS, there was an attempt to use a calcium polystyrene sulfonate. However, the patient spontaneously abandoned this treatment due to self-reported gastric intolerance. And at that time, the physician treated to reintroduce ramipril plus Potassium, ramipril 2.5 plus Potassium 8.5. this was in December 2017. In January, there was an up-titration of Potassium, 16.8 grams, under the same dose of ramipril because the serum potassium was 5.4. But in February, it was possible to up-titrate ramipril to 5 milligrams, then to introduce in March eplerenone, and then to further up-titrate eplerenone. Then in May, ramipril was replaced with sacubitril valsartan under the same dose of Potassium without recurrence of hyperkalemia. It was not possible to further up-titrate RAASI, especially sacubitril valsartan, because of symptomatic arterial hypotension. But nevertheless, the patient is now stage 2 NIA and is really stabilized under optimized therapeutics due to Potassium. So my concluding slide is I hope I have convinced you that RAASI are demonstrated cardiorenal protective drugs in the cardiorenal continuum, but they may induce hyperkalemia, while hyperkalemia is associated with poor clinical outcomes. Hyperkalemia is a trigger to RAASI discontinuation, and we are fortunate because now we have a new tool, because Potassium is approved to treat hyperkalemia, and interestingly, furthermore, Potassium enables RAASI. And I would like to thank you for your attention.
Thank you very much, Professor Arzwinov, for this very informative talk. Really, we have a lot of information learned today about it. Appreciate all your effort in this talk. Now, we will have a poll now before we go to the final talk. So please show us the poll. So please answer this one. You have about a minute or so. Okay, so if you finish, we can see the answers now. Great. So definitely we have some improvement in the answer here, and hopefully by the end of this talk we can open for discussion if you have any question. So thank you very much indeed. Let's move now to our last speaker, Dr. Fakhr Ayubi. She's the president of the Cardioclinical Pharmacy Group, and she's the organizer of this talk really with V4 Pharma. And I really want to thank her for her effort to upgrade our knowledge about the updated management of heart failure and hyperkalemia and patients with as well renal impairment. So please, Professor Fakhr, go ahead.
Assalamu alaikum wa rahmatullah. Good evening, everybody. Thank you very much, Prof. Arafa, for the nice introduction. Thank you, Saudi Heart Association, for organizing this webinar. After my two great speakers that were talking about the potassium and the hyperkinemia and the problems that we are facing with, actually, as a pharmacist, I'm facing a problem from two sides. First of all, telling the patients to take medication, and the other problem is that their medication is causing them a problem and a side effects, which is hyperkalemia. So I have to weigh the benefits and the risk, and I have to educate the patient. That's why I'm calling my presentation medication adherence and then patient counseling. So you can make the patient as a judge. Once he develops these problems, what to do and how they should react. Just to tell you كل عام وأنتم بخير جميعا. العيد على الأبواب والحج القادم إن شاء الله. I hope إن شاء الله يعني الحج القادم يكون بظروف أفضل، وإن شاء الله هذه الجائحة جائحة كورونا تكون يعني إن شاء الله على نهاية، وكل عام أنتم بخير مسبقا، لأنه هذه الويبينار تعتبر الأخيرة قبل بداية إن شاء الله الويبينارات اللي هي بعد العيد الكبير إن شاء الله. To tell you something that we always talk about adherence. Adherence, to be honest with you, is that telling the patient to respond to an action or recommendations that are given to them by the healthcare providers. We always think that adherence is just adherence to medication, and this is not true, because patients should adhere to their appointment, they should adhere to their health lifestyle modification, and of course to other things on the top of medications. So the WHO was so clear. It was not just telling us the drug adherence, no, it's telling us all kind of adherence that is related to the instructions given to the patient. The non-adherence it means that either patient do not even fill the medication from the beginning, or they are not refilling them on time, or they are continuation of the medications for chronic disease, or they are taking it more than expected or less than supposed to be given, or they are taking it on the wrong time, like what happens with statins sometimes. So all these are in the category of non-adherence. What about the terminologies that we hear a lot from pharmacists around you and from other colleagues, of course, in the Saudi FDA? They tell you that there's a medication adherence, and this means that this is related to the time, the dosing, and the frequency of the medication itself, the drug. Medication compliance, it's almost the same, but here now the patient is complying to the physician order rather than only just the medications. Medications persistence, now patients might have taken the medication on right time, right dose, but they don't stay for long. Like some of them think that hypertension is just like 1 or 2 dose, 3 dose, 1 month, 1 year, and then he will stop. This is also called non-adherence. And there is something called the proportion of day covered. I'm not going to go into deep details in that, but I would really like to share with our physicians, especially our webinar has now 3,000 audience from different specialty. I want to just share with you that we calculate the adherence percentage for these patients. And it's a simple calculation, and we do it one by one. Now, proportion of days covered, usually you calculate the adherence of the patients to one medication in 1 day. If this is okay, like he has a drug who's supposed to be taken twice a day, and he took it once a day, this is considered non-adherence, even if he took it once. The other thing, which is very important in cardiac patients and in chronic disease patients, is that there's something called persistence, and as I told you, there's something called non-adherence. What do I mean by that? There is a 3 component for adherence. He should start on the right time, and also after that, implementing the proper instructions, and when to discontinue or switch from one to the other or stop it totally. Now, all these 3 components will help us in giving the different types of non-adherence. As you can see, some of the types are intention. Patient doesn't want to take medications, and some of them are non-intention. And most of our cardiac patients, to be honest with you, it's most of the time the second type. They have a lots of medications, they have a lots of misinformation that are given to them, a lots of side effects. So all of this is a type of non-adherence. That's why it's important for me, because I need to measure that. I need to calculate the problem. Why adherence is important for me as a pharmacist? As simple as that. It will reduce the hospitalization risk of your patient. And we will see that on petenomere and on the hyperkalemic patients that we're talking about today. If you have hyperkalemic patients with a very high potassium level, in the end, you have to admit the patient. And in this case, it will be a risk on the patient's life and, of course, on the budget. The other thing is that we have to, as I told you, measure the adherence. There's several ways, lots of methods. There's some of them with advantage and disadvantage. I'll just go very brief on some of them. Direct observation, maybe all of us will do this thing, which is I tell the patients to bring the medication in the clinic. I will see the medications, are they empty or not? So this is called direct observation. The other one is by measuring the level. Some drugs, we can measure the level, so you can know this patient is taking the proper medications or not. And the other one is detecting the effect of the drug on the patients. Like if he's taking his hypertensive medication, of course, he should come with a proper blood pressure reading. The indirect methods are patients reporting method, like what we do in some clinics. We have some tools that will tell the patient, every time you take your medication, you click on I did. They will come next appointment. We'll get a report from them telling us that he took like 28 doses out of 30. So we got the report. The other one is, again, by just counting the pills, which is very simple and easy, everybody can do. And the other one is the patient assessment methods. And again, honestly speaking, you cannot apply all of them in Saudi Arabia because we have patients that are over-compliant, patients that have a file in different sectors, in different hospitals. And it's not easy to predict if they are really taking the medications or not because they have file in every hospital. There is also a Morrisky score. This is a pharmacy score. And it's very easy to apply. You ask the patients 8 questions, and it tells you that if this patient is intention to take his medication or not. It will tell you if he forget to take the medication, which is again something that we should help them in. And of course, why are they stopping taking this medication? It's very easy to apply. I do apply it in the clinics in our hospital, and I can get from them if I'm educating the patients, am I doing a good job? Is my patient improving in his adherence or not? Also, there's a calculation ratio to tell that this patient is good compliant or not. The average usually is from 80 to 95. Less than 80, he's a poor compliance. More than 95, which is very rare to find in cardiac patients, he's an excellent compliant. More than, of course, 100, he's considered to be a double or over compliant. As I told you here, you can see now, and this is an actual real case in the clinic, a 56-year-old female, she's coming with all these medications. As I told you, it's a duplication. She's taking the same medication, and she will develop definitely hyperkalemia because she's taken lisinopril twice, and she's taken furosemide twice, and spironolactone twice, and metalazone. Now, this is, imagine if it's happening in 2 or 3 of your patients, how can you really tackle this, and how can we come over this problem? What we do in pharmacy, we calculate the proportion of days covered, as I told you, on the total number. And it will give me, as I told you, the percentage. Now, it will give me a range from 0 to 1. The value that goes from 0 to 1, you are doing a good job. The more you go to 0, it's better. The more you go to 1, it's bad. As an example here, you know, we don't have one drug. Usually there's patients with, let's say, 4 drugs. Over the 120 days, he's compliant with the first one, excellent compliant with the second one, but look at the third one. He missed 8 days, and from the last one, he missed another 8 days. So you subtract the total, which is 140, over the total of 120. 120 is the full month, multiplied by 100, it will give you the percentage of adherence of these patients. Again, I'm not going to complicate things, but I'm just trying to tell you it's a science, and we do really get the information from the patients to help them, because it has an impact on the patient's life and on the budget of the hospital. In the US, they pay billions, 290 billions per year for the non-adherence. In Europe, it's not better. It's 1.25 billions. In Asia, again, there is no predictive amount of money reported, but still it's a very high percentage of non-compliant because we are under-reporting it. It will, again, increase the hospitalization and the risk of hospitalization. And we might just ask ourselves why patients are not adherent to their medication. There's 5 elements, and it's actually, I'm not going to go into deep details on each one of them, but some of them is related to the patient themselves, and some of them could be related to the system and the hospital itself. The appointments are very far, there's no appointments, there's no medications, and so on. And there's the third one, which my concern today is the side effects of the medications, as you can see here. Now, it could be, of course, the drug effectiveness is not effective. It could be the duration of the treatment, very long duration. It could be a complex of different timing of the medications, or the side effects of the medication, which is exactly what's happening with our chronic heart failure patients. And they are really developing hyperkalemia. And I saw that myself in the clinic. And when they develop it once, usually it's not the only time. At least they will get it 2 or 3 times per year. And this is really scary because it comes from the original drugs that they have to be on. The golden guideline therapy that they should be on, which is the ACE inhibitor or the ARBs, or of course the MRA. So again, once this happens, this is another way of tackling the adherence of this patient. Another one, it could be something, another factorial problems, the severity of the disease, it's not painful, and so on. And the pharmacoeconomic part, which is a very crucial element. Because as I went through some discussions with my colleagues, they're telling me this drug is expensive. So the patients, if he cannot afford it, most of the time they will not buy it. So you always have to think about the pharmacoeconomic, socioeconomic, of course, part. Hyperkalemia is one of these actually elements, because most of the time we have to admit the patient, and we have to sometimes put them on diuretics, sometimes we have to put them on acute medications, which means that it's costly for them unless they are treated in governmental hospitals. Chronic medications, chronic disease are really a problem, and we need to concentrate on the adherence for example, hypertension medication, because if there's no adherence, about 50% risk of hospitalization have been reported in those patients. The benefit of medication adherence, of course, it will improve the outcome of your patients. It will decrease the rehospitalization, decrease the emergency visit, and all these, of course, consequences of cost-effective. And of course, it will give you a better outcome on the patient. How can we get this adherence on the field? You need to have the trust of your patients. You need to understand and, of course, educate your patient, believe in what they're saying, put yourself in there instead of them, and of course the ability to follow them, to see them frequently, and of course the accessibility. They have to have a way to get to you back in an easy way. There's some methods that we could use actually to improve the adherence of those patients, and there's a lot of them, like electronic reminder. For us, we are using actually a mobile application, MediCoach. What we do, you implement it. It's a free, it's in Arabic and English. We just put it inside the patient's mobile or the caregiver, put the drugs names and doses and frequency, and tell the patients just to click on yes, I took, till they come back again to the clinic. This is one way, of course, of predicting or improving the adherence of the patient. The role of pharmacist is not just working on the adherence, it's counseling itself. What do you mean by counseling? You have to talk with your patient about the disease. Explain again. I know physicians do really explain for their patients, but pharmacist has to continue, has to focus more about for example, hyperkinemia. The pharmacists need to tell the patients what to eat and what not to eat. And they have to tell them what drugs that could cause this problem. If there really happens, what they should do. And of course, the other thing is that, okay, if I have other problem, if I face another complications, what should I do in this case? The Saudi Clinical Pharmacy Group are working now on patient counseling, awareness, and education. We are sending information through the social media, and I will talk about it later, but we just want to counsel the patients who will take the Bicarbonate, for example, which is a potassium binder. They should know that it's an oral medication, it's a sachet. The sachet is supposed to be dissolved in an apple juice. It's better for the absorption. And usually we tell them to take it with or without food, no problem, but in a fixed time daily. Usually the starting dose, as you can see, is 8.4 grams. This is daily. Sometimes we go even higher, depends on the potassium level. The other thing, you should tell the patient to come back again to the clinic to do another potassium level and to see, is this an enough dose or should I go upper or a lower dose? As I told you, we are now starting a campaign, and VFAR, I really want to thank them for this. They will actually sponsor such an education part and awareness to the patients. As Prof. Arafa told us, that hyperkalemia is a silent killer, and patient and people and public should know about that. They should know about this through the social media, as we did some events and some, of course, materials that we are sending them through the Facebook and Twitter. We're trying to see which is the best tool for us. Most of the people now, they have their mobiles in, so it's easy to send them this kind of information. We started by telling people where we can find a potassium in their food, like for example, in Saudi Arabia, it's the date. So, okay, you have to be careful. If you take it with a limit. Also, orange could be a problem. Banana could be another problem. So this has to be given to the public in a nice and an easy way, of course, in Arabic and English. And also, we will send also some videos in order to counsel those patients and our people or public about hyperkalemia. So I do believe that the non-adherence is a problem. It's a concern. But again, the adherence itself could have a side effects, which we have to work together how to come over this and educate the patient how to come over this problem. It is a barrier sometimes. We cannot handle it easily, but you have to sit with the higher administration, tell them how can we reach those patients. Another thing is that there should be a tools and a method to calculate your patient's adherence. There should be a tool and a method to follow your patients properly. And of course, try your best to simplify the medications as much as you could for your patient. Thank you very much. And Prof. Arafa.
Thank you very much indeed, Professor Fakhr, for this very important information about adherence and the patient management. Now we open the floor for discussion. We have very frequent question being asked here now. Let me start with Dr. Abir. Now, in your current practice now, Dr. Abir, in your clinic, if you see a patient had acute hyperkalemia now, and he's already on RAAS system, and he's heart failure patient who need to be on them, and he's taking as well corticoid inhibitor. What do you do for him currently?
So for me, we target a higher, I have a higher threshold of potassium. So, up to 5.5, I actually don't change the medication. I won't up titrate at that level, but I would not change the medication. And if the patient is congested, so probably you're going to increase the diuretics. So I would just, maintain the same, maybe increase a bit of the diuretics and just recheck the potassium in a few days. If it's higher than 5.5, like between 5.5 and 6, then we definitely, the first drug we hold is the aldactone, and I don't up titrate any other medication. And I rarely withdraw the ACE ARB or the ARNI for hyperkalemia. But yes, if it's 6 and above, then at that time, we're actually either giving calcium resonium, or sometimes we are admitting patients based on what risk profile we see them in. To treat them as an inpatient for the business standard care of anti-hyperkalemic measures.
Yeah. You don't have Patimor yet available in your pharmacy, in your clinic?
I don't have that yet.
We don't have yet. So what do you think, Professor Patrick, about a patient who is coming now with acute hyperkalemia in your clinic? What do you do in your clinic exactly?
Well, actually, there are two different settings. So, what do you mean with acute hyperkalemia? Because
I mean,
he's known
to have. He's heart failure patient with stage say 3 CKD, and he came to your clinic. He's taking already ACE inhibitors, and so his potassium now came to be 5.7. Let's say, what you would do with him usually?
Well, the first thing is to determine whether the patient is an emergent, should I refer to an emergent condition or not? Because we must be aware of the fact that new potassium binders, Patimor, including Patimor, are not approved for the treatment of hyperkalemia in emergent conditions. So should the patient present in an emergent condition, I will proceed most likely with once hyperkalemia is confirmed, on depending on the potential EKG changes, with beta-2 agonists or insulins, glucose, and so on. So these are emergent conditions. But if the patient, and I guess this kind of patient you are referring to, is not a patient presenting in emergent condition with a potassium of 5.7, what I would say is that so far, reaching the fact that I don't have access to Patimor in my country either so far, because it's not yet reimbursed. I'm following the ESC guidelines, which mentions related, for instance, to RAASI in FREF patients, that RAASI could be maintained as long as serum potassium is below 5.5. But if it is above 5.5, I need to consider down titrating RAASI doses or even discontinuing RAASI, which is unfortunate. But this is the reason why. My guess is that there is a tremendous need toward RAASI, toward hyperkalemia management with new potassium binder, which may be maintained on the long run. And we have this possibility now in those countries where Patimor is available, because proceeding that way, we may treat hyperkalemia, get it normalized, and maintain RAASI on the long run.
Now, Patimor is available in the kingdom here, because one of the questions had been asked whether it's available in the kingdom. It's available in the kingdom, definitely. And some pharmacies do they have them really, and we can start them using them. The question will be very clearly here that is not for acute measurement, but for prevention of hyperkalemia, to maintain the medical therapy for the patient who need on them. There's a couple of questions about how we can correlate hyperkalemia with diabetes. I mean, how diabetes raise hyperkalemia? Dr. Abir, if you don't want to, why diabetic patients should have hyperkalemia?
So there are probably multiple mechanisms. One of them are because of lack of insulin, they introduce intracellular shift. So there's as we have seen earlier, the pathophysiology of the potassium, majority of the potassium in our body is actually intracellular, not extracellular. And insulin has a role of activating the sodium potassium co-transporters in shifting the potassium into the cells. So one of the hypotheses are that the lack of insulin or insulin resistance leading to increasing in the extracellular space rather than intracellular. And there is obviously the other mechanism, which is the diabetic, probably related to diabetic nephropathy or renal tubular acidosis associated with diabetes. I'm not a nephrologist, I'm not going to explain that much, but I think there's another pathogenesis associated with diabetes that may lead to hyperkalemia.
Okay. Dr. Fakhr, about the way we measure the potassium in the blood, does applying tourniquet on a patient arm make the difference in the measurement of potassium?
You mean the level of potassium they mean, or what
Yeah,
are they?
Yeah, basically asking question, when we collect the blood sample from the patient, putting the tourniquet just to make the vein clear, does make a difference in the measurement of the potassium?
Well, the most important thing is that not to destroy the cells. It will give you a false hyperkalemia. Maybe this is what they are asking.
Yeah.
I need to add just a point to Dr. Abir regarding diabetes and hyperkalemia. Maybe I do agree what she said, but I think also the medications themselves. Now, the insulin is one of them. Even the others, like the oral antidiabetic, they are causing the same problem, which is hyperkalemia, which is shifting, again, the potassium extracellularly, which could be the cause of hyperkalemia. And the other thing maybe could be from the not ability of the kidney to excrete the potassium, because of we know that after a while they will get complications in the kidney. So maybe it could be the accumulation of potassium also because of not able to exchange it.
Okay.
Well, if I may
please,
add,
go ahead.
I fully agree with what was said by my colleagues, especially in the sense that diabetic patients are more likely to present hypoaldosteronism, by the way, which may contribute to the higher likelihood of presenting hyperkalemia, especially acknowledging the fact that they are likely to be presenting with impaired kidney function and to be treated with RAASI.
Great. The question, Professor, to you, is mortality related to potassium level or due to stopping of the offending beneficial drug RAAS and ARNI? So why the mortality is high is because the potassium is high, or we stop the beneficial action of RAAS and ARNI?
If I may, I think that there is a strong rationale toward arrhythmogenicity of high serum potassium. Our cardiology colleagues know better than me as a nephrologist that patients with hyperkalemia may present QRS enlargement, which may ultimately lead to life-threatening arrhythmia and death. So there is a pathophysiological rationale which may provide a link between hyperkalemia and death. That said, my guess is that on top of that, the fact that patients presenting with hyperkalemia are more likely to get discontinued RAASI may contribute through the RAASI discontinuation. This is actually what our own data showed on others from Lars Lund in the Swedish Heart Registry, that hyperkalemia may also be, beyond being a factor, maybe also a risk marker associated with RAASI discontinuation and with associated poor outcomes. So we may have both, to make it short.
Okay. Dr. Fakhr, for your question, since hyperkalemia is mostly silent, how we can educate our patient taking hyperkalemic medication for early symptoms of hyperkinemia?
Yeah, exactly. This is the second part of the presentation when I said that patients should not be only educated to take medications. We always have to tell them that this medication might cause a problem. And this is why we take them one by one in the clinic to explain to them that this medication might cause hyperkalemia. So first of all, we educate them not to take a food that will increase their potassium. So we give a space for the drug itself to work. And then after that, we'll tell them to come back to us with, of course, lab results. So we can follow that with them. And we will tell them that this hyperkalemia will not be harmful if we're able to control it properly and from the beginning.
So Dr. Abir, in your clinic and on every governmental clinic, we have very busy schedule. How do you schedule your patients to follow up after you introduce to them either the ACE inhibitor or ARBs or RNA system? How do you see them after your prescription has been given to them as outpatient?
So we're usually scheduling a 4-week visit for these patients, especially if they had a baseline normal renal function, normal potassium. So at 4 weeks, especially after switching medication or increasing doses, we ask them to come in and get a lab test done and make sure they're on the right track and we can optimize further. If I am concerned that someone already had baseline renal impairment, they already had history of hyperkalemia in the past, then I would ask them to come in 2 weeks to do that. And we have a walking clinic, which is nurse-led. So they are actually doing this part on our behalf. So bring the patient in, doing their labs, and then checking in with us. So we are accommodating in your visits.
Professor Patrick, how do you follow up your patient with tendency to get hyperkalemic?
Well, similar to what my colleague stated, so it is of paramount importance to explain what are the benefits and the risk of each treatment. So education is key. And in our region, we used to implement a disease management program in the Lorraine region. So it was an experimental one named ICALOR. We published these results a couple of years ago, showing that during the period of time the ICALOR program was implemented, this was a multidisciplinary program where cardiologists, GPs, nurses worked together with patients to explain why it was so important to properly monitor patients, to educate them. But during the period of time where the disease management program was implemented, there was a decrease in the hospitalization rate for heart failure in this region compared to all other regions in France. And this was an experimental program. Funding was stopped. On hospitalization went up. We published these unfortunate results in European Journal of Heart Failure, which clearly demonstrates that a multidisciplinary effort toward education in order to make patients be convinced that to retrieve the best benefit of the drug we are prescribing them, they need to be properly educated and monitored. And potassium is one of the key components of this feature.
Okay. Now, Dr. Abir, regarding the new antidiabetic agent, the SGLT2 inhibitor, when we add them to the current therapy to the RAAS system, can they decrease potassium or not?
In my practice, I haven't noticed any significant change in the potassium. Yet, not a lot of patients on SGLT2 yet in my practice, but I haven't seen a significant change or episodes of hyperkalemia with the SGLT2 in addition to the other therapies.
Professor Patrick, do you have any experience with the new class of heart failure SGLT2?
Yeah. Unfortunately not, because the first SGLT2 inhibitor reimbursed in France was reimbursed only a couple of months ago. So we were unfortunate we did not get access to these drugs until recently, but from the trials which got published, as far as I'm aware of, I would say that they are rather neutral concerning potassium. So I would not expect potassium normalization with using these compounds which are assumed to be rather neutral.
There's one question about the safety. Yes, go ahead, please. Go ahead.
Prof. Arfa, if you don't mind, I might add a point here.
Sure, please.
We had an experience with one of them, especially that we have the multidisciplinary team in Khalid University.
Yeah.
And we started few patients on these new medications. And I think that the point here, they might develop a normalization sometimes because they come to us with uncontrolled diabetes. So the one of the elements that you might say I'm doing a good job with my patients is the A1C, hemoglobin A1C, which is very important. But the other thing is the potassium levels, because some of them, they take it on the top of insulin, and it will give you a direction or an indicator that you are in the right way of controlling the patients. So some patients usually have a maintenance of their potassium better than without these medications. But till now, we only have a short experience, which is not more than 6 months. But I think we need to have even more data about that.
Thank you very much. There's a question about the safety of Batimore and other agents used as chelating agent. I want to hear Professor Patrick about the safety issue. You mentioned this in your talk, but can you stress the fact it is really safe and it's not really something that might be?
From the clinical trial data, what I may state is that compared to old generation potassium binders, where there were no randomized control data at all, we have now randomized control data, which led to the approval of these new compounds. With regard to Patiomere, we have 52 weeks the Amethyst diabetic nephropathy trial, which clearly demonstrated that this treatment option can be considered on the long run with a long-standing normalization of serum potassium in previously hyperkalemic patients. 100 of them treated with RAASI initially, which is of utmost importance, and that almost all of the patients, more than 90% of the patients, are able to be adherent to the drug, while the AEs are really mild of magnitude and of frequency. The most common adverse events are mild GI effects, such as constipation. And again, many patients did have disparation of constipation despite the maintenance of Patiomere. So this is, which is interesting. And another thing to consider is to monitor magnesium, because hypomagnesemia, never symptomatic, may happen. So it is worthwhile to consider monitoring magnesium. And I would conclude with something which is key. And as I mentioned, both hypokalemia and hyperkalemia are of concern. And with Patiomere, there was no issue with hypokalemia. So this is a drug which is able to get potassium normalized without inducing hypokalemia, as long as potassium is properly monitored, of course.
Great stuff. Now, the question about the role of sodium bicarb to decrease the potassium. You mentioned in your talk that we can use sodium bicarb to reduce it. How much is that really? I think Dr. Abir mentioned it, or Professor Patrick, one of you, that one way to reduce the potassium is used to introduce a sodium bicarb. But I have some concern about that myself, both for renal patient and heart failure patient. So I'd like to hear your comments about it.
So I mentioned that in my talk because I know that at least in some countries, some colleagues may find this therapeutic option as being quite attractive. And I published with my colleagues on the support of VE4, by the way, a European survey, 5 countries, where we did study the behavior of physicians in the presence of recurrent hyperkalemia. And by the way, if I remember clearly, Italian colleagues were more likely to use bicarbonate compared to German, UK, French colleagues, while French colleagues were more likely to use potassium binders, for instance. So I know that some colleagues may be tempted to use bicarbonate. I wouldn't myself because of the reasons I referred to, on which I may share with you, of course, a link to fluid overload on most likely modest effects.
Great. Now, we know that hypertension, we encourage patients to take potassium containing food because potassium improves the hypertension. The question will be, is that really a fact that if we improve the potassium in the diet, we improve hypertension management, and how that will be, I mean, contradicting what we have talked tonight about it? Does potassium improve hypertension or not?
Can I just?
Please, go ahead.
Yeah. Does it, you mean controlling potassium? This is the
No,
question,
no.
yeah?
Some diet which contain high potassium might improve hypertension management. This is well-known in hypertension management that some of the food which contain potassium in them might improve hypertension control. Now, when we add aldosterone, for example, to the patient with resistant hypertension, the potassium will increase in the blood, and that might improve the hypertension management control. Does that make any sense, or what do you think about it?
Maybe they're tackling the sodium-potassium exchange. So when you're increasing the potassium and the level, you are exchanging it with sodium, which is, again, controlling the sodium might have an indirect way of controlling hypertension.
What do you think,
Sure,
Professor?
yeah.
What do you think, Professor Patrick, about potassium and hypertension?
Well,
you are nephrologist.
Yes, what I would say is it depends on the clinical setting. So if you have a normal kidney function, normal kidney function, of course, there are epidemiological studies which show that the higher potassium intake, for instance, within the framework of a DASH diet, may be associated with a lower prevalence of hypertension. So if we are dealing here with a patient without any kidney function impairment, my guess is, okay, it's better to take healthy food. But as soon as we get some kidney impairment with alteration in a sodium handling from on reabsorption from the kidneys, we are in trouble with the potassium. And here we get the U-shaped relationship, which happens to be especially problematic for hyperkalemia. And I certainly would discourage my patients to take any potassium supplement despite their high blood pressure level, because this may ultimately induce hyperkalemia and potentially death. So two different settings. CKD, you are at risk of presenting sudden death should you present hyperkalemia. So I would prevent my patients to take any potassium supplement.
Thank you very much indeed. I think the time is already come to the end, and I would like to thank everybody. I really learned a lot tonight, and especially about really, it's not really a good idea to reduce your very important medicine, especially the RAAS system and the mineralocorticoid inhibitor for patients who really need them. Now we have to find a way to improve the potassium rather than stopping this essential medication, which has been shown different outcome both for heart failure patient and nephropathy. Thank you very much, Professor. Thank you, Dr. Fakhr, for this very important meeting. Thank you, Dr. Abir, for your visiting with us tonight. I learned from all of you, and hopefully we'll meet you more in the future. And we have to have really a face-to-face meeting after this pandemic over, and everybody, I hope, have a healthy life, and Eid Mubarak for everybody in this group. Thank you very much indeed. Appreciate all your help.
Thank you very much.
You are very welcome. Wish you a good day. Bye-bye.
Bye.
Bye. Take care.